All right, let's call this meeting to order. Can commissioners who are on the phone please identify themselves?
Commissioner Khan.
Welcome, Kenny.
Okay, great.
Anybody else? Okay, we do have a quorum. First agenda item is the approval of minutes. Included in your packets are copies of the minutes from the February 19th public meeting of the Commission. If there are no changes or corrections, I'll entertain a motion for approval.
So moved.
Any discussion? All in favor? Aye. Any opposed? Minutes are approved. Next, I would like to introduce a new commissioner, Maureen Carr-York. Maureen is an attorney and a public health nurse with a wealth of experience in community issues. She earned her RN from Catholic University, same time as Fran, and practiced in ambulatory and hospital settings. Later, she earned a law degree from Georgetown University and was employed at the Department of Justice, Torrance Branch, before joining the Health Law, Product Liability, and Medical Malpractice Group of Smith, Somerville, and Case of all law firms. Ms. York has a strong commitment to public service. She has served on the Arundel County Board of Education during the 1990s and brings a strong, wide variety of interests to the Commission, and we look forward to her being an active participant and contributor. Commissioners, you've received a written update from our centers. Ben, do you or any directors have anything you'd like to add?
Thank you, Chairman Tanio. I too would like to, on behalf of the staff, welcome Commissioner Carr-York. I'd also want to note the contributions of Commissioner Barbara McLean, who served with the MHCC as the commissioner for more than 7 years. I did thank Commissioner McLean on behalf of the staff. She had some tough issues she had to handle in terms of several CON decisions, and we certainly appreciated her contribution over that time period. I'm sure the commissioners will agree she made a contribution to the work of the MHCC.
Any other updates?
Other
Good afternoon, Mr. Chairman, members of the Commission. I have a couple of brief updates. In October of 2014, the Commission awarded 3 telehealth grants with a combined total of about $87,000. These grants included a one-to-one financial match requirement. The telehealth use case that was awarded is focused on transitions of care between long-term care and post-acute care settings, and was selected by representatives of the telemedicine task force. In February, late February, a staff convened a telehealth symposium in Annapolis that showcased the work of the 3 telehealth grantees, which are Atlantic General Hospital and Berlin Nursing Center, Dimensions Health Center, Healthcare System in Sanctuary Holy Cross, and lastly, the University of Maryland, Upper Chesapeake, and the Bel Air facility of Lorient. Commissioner Montgomery, thank you, was in attendance at this event. And just to note, in April, staff plans to release a telehealth application for grant announcements to fund up to 3 additional telehealth use cases. Next, I wanted to tell you briefly about our work in collaborating with CRISP on an ONC grant application to advance connectivity with ambulatory practices. ONC anticipates making up 12 awards ranging from $1 to $3 million. Applications are short turnaround time, are due on April 6th, with the anticipated award date around June 12th. And on a grant that is very near and dear to many of us is the Practice Transformation Grant. We're anticipating hearing from CMMI, which is the Centers for Medicare and Medicaid Innovation, in early April on whether the Maryland application will be funded. They anticipate funding up to 35 applicants, ranging from $2 to $50 million. So we're, at this point, overly confident, and hopefully that prevails as we go forward. Mr. Chairman, members of the Commission, thank you. That concludes my update.
Move to agenda item number 3. Kevin McDonald will present the staff report and recommendation on a certificate of need application filed by Hospice of Washington County, Incorporated, for the construction of a 12-bed inpatient hospice to be located in Hagerstown. Kevin?
Thank you. The applicant, the Hospice of Washington County, is one of only 2 hospices authorized to provide services in Washington County, and practically speaking, the only one that has been delivering services there. They've done an admirable job in terms of the hospice penetration rate. State Health Plan has a target rate of 0.45, and that is probably not being met in most jurisdictions, but Washington County's rate is 48%. Probably as a result of that growing rate, their hospice admissions have grown, have almost doubled between 2009 and 2014. The project is a 12-bed inpatient hospice to be constructed on 4.8 acres of land on the Meritus Medical Center campus, which will be leased for $1 annually. Cost of the project is slightly over $7 million. The financing plan is cash of $1,560,000, philanthropy at $2.7 million. There is $250,000 in state funds, state bond bills, and debt of $2.5 million. In looking at the application vis-a-vis the mandatory criteria, the staff finds that the application and the applicant are in compliance with the standards in the state health plan. Examining need, this would be the first general inpatient hospice, first and only in Washington County, although inpatient services are currently being delivered by the hospice within the acute care hospital, within Meritus. The total admissions in 2014 were 1,011. Total patients served 1,282. In trying to project from those statistics to converting that into a need for inpatient hospice, the state health plan doesn't have a formula in the state health plan. However, both the applicant and the staff applied formulas that, a variety of formulas that are used in the industry and that have been used in prior reviews of inpatient hospices. And using those approaches, projected an average daily census at a low end 8, and at a high end as many as 14. Thus, it seems thus we're pretty confident that planning at an 85% occupancy rate, 12 beds would be justified. In an analysis of cost-effective alternatives, the applicant did look at the alternative of constructing a hospice unit within the hospital. That was ruled out as being cost prohibitive. Also, not really in concert with the goal of providing hospices in a dedicated setting, hospice environment. The proposal is both lower cost and a more appropriate setting in terms of dedicated hospice facility, dedicated hospice staff, better approach from the perspective of patients and families. In looking at the viability and financial feasibility of the project, the applicant does have the cash that it is committing in hand. Also in hand is $2.4 million in gifts and pledges, and there are, as far as the debt, applicant has proposals from several banks. Operationally, the hospice is projected to break even and turn a profit probably by the middle of the third full year of operation. In examining the impact on other providers, it is the only provider that would really be impacted by this is Meritus, and I think their view is pretty well expressed in a letter of support, as well as the lease for the land at $1 a year. So the impact on the health system is positive. And based on a look at staff's review of the criteria and standards, we recommend approval of this application. And with us today to represent the applicant is the CEO, Eric Clemes, Jerry Ann Hammond, the Chief Financial Officer, and Shelley Steiner, who's Director of Strategic Initiatives.
Can I first start with a motion to approve the Certificate of Need?
For discussion, so moved.
Okay. All right, Kenny, I'll take that as a second. Any questions or discussion? Open it up. Fran?
Thank you, Kevin. The proposal is to open 12 inpatient beds, just freestanding, on the grounds of the health system. Currently in Washington County, such patients are served as inpatients in the hospital. Is that the correct situation? For hospice patients needing acute inpatient care. So they're in the hospital now, and this would establish a separate facility, more hospice-like.
I think that's generally correct. The applicant may want to speak to that. In reading the application and in discussions with the applicant, I think most of the people that are receiving inpatient hospice care are getting it in Meritus, provided by Hospice of Washington County. Many of those patients, however, probably spend a good bit of time in the palliative care unit, either in lieu of inpatient hospice services or for a period of time before they are then transferred to hospice for a shorter stay.
I think I see that the applicant agreeing with you on that.
I'm in total agreement. Please come to the microphone and identify yourself.
Eric Clemes, Chief Executive Officer, Hospice of Washington County. Yes, I mean, many of the patients are either more likely direct referrals from Meritus. Many of them, again, are receiving services through the palliative care unit, have died in the palliative care unit without hospice services. There's a small percentage of them that are receiving general inpatient services in a skilled nursing facility. And there's maybe 2 facilities that meet the criteria for general inpatient services. And the percentage is so small that it's not even noteworthy, to be quite honest.
So just a follow-up question then. This commission, this body has recognized through a number of actions the tremendous value that hospice, both inpatient and community-based hospice, provides to its patients and to family members, and has recognized that. One of the things that has come out in our past discussions is that the choice, the elective choice by patients to enter hospice does not seem to be distributed racially or ethnically in a way that suggests that there's access for all racial and ethnic groups to participate in hospice care when it's appropriate and indicated. So just as a comment, to overcome or to address some of those cultural barriers that might exist to make sure that hospice is available to all patients that would be appropriate for that care. If you have any comments.
I'd actually like to speak on that. I'm just a little bit of background about myself. I'm a native Washingtonian, so I'm very familiar with
That Washington County or
Washington, D.C.
Okay.
Washington, D.C. So I'm very familiar with Prince George's County. I have family in Baltimore. When I first started, that was one of the first things I identified. So we had lots of initiatives to reach the African American and Latino community, and even the impoverished community. So we established multiple life centers throughout the county in order to support those communities and raise hospice awareness. We met with many of the church leaders as a result, and lots of education programs, lots of outreach programs. We will continue to do that. Over the last couple of years, our percentage of African American penetration into hospice as well as Latino actually meets the percentages or are consistent with the percentages of hospice penetration that Maryland Healthcare Commission requires.
Great.
Let me just follow up on Fran's point. I mean, that's great to hear. And when we look at table 3-3 on page 5, you see that Washington County and Frederick County have really moved up pretty, track with each other, and then the other 3 counties haven't. I'm just curious, in the hospice community, do you see active sharing of sort of these best practices? Do people in the other counties sort of reach out to you for advice?
We do. I think in a lot of the counties, I'm going to try to be as politically correct as I can.
Sure.
And a lot of the counties, I'll say Baltimore and Prince George, for example, there are lots of opportunities for improvement throughout the healthcare delivery continuum. So it's not just when you get these patients that are chronically ill that hospice is failing in its mission. It's pretty much the entire healthcare system failing in its mission. Hospice is just one component of that. The other thing is, and I know there have been frequent discussions about choice, the backlash sometimes, the unintended consequence rather of choice is you have hospices spending large percentages of their revenue marketing and not dedicating it to outreach and patient care. So you see the margins get a lot, so the little guys really at some point can't compete. And, even in my not-for-profit, and my for-profit days rather, I saw lots of unrealized opportunities as far as reaching those disadvantaged communities. And those are huge investments. You have to want to be there. You have to remain there for the long haul. So I hope that answers your question.
I appreciate that. Thank you. Other questions or comments? Seeing none, let's vote. All in favor? Aye. Any opposed? You have your certificate of need.
Oh, well, thank you. Thanks again. We won't let you down.
All right.
So before you leave, if we can just help you that, as you probably know, we have some initiatives in both Baltimore City and Prince George's County to expand use of hospice among minority populations. So we may tap into your experience in Washington County, which does seem a bit odd, but it sounds like you're making more progress than some of our larger jurisdictions in that regard. And I think that'd be helpful if we can get you or some of your staff to provide us our advice.
That's terrific. Thank you. Let's move on to agenda item number 4. Nikki Majewski will provide an overview of staff's draft amendments to COMAR 10.25.17, benchmarks for pre-authorization of healthcare services. Joining her at the table is Angela Ebat. The Commission will take no action today. The presentation, rather, is a prelude to the start of an informal comment period for all participants, and at the conclusion of the informal comment period, staff will then consider suggested changes, submit the regulations to the Commission for adoption as proposed permanent regulations. Nikki and Angela.
Great. Thank you. Good afternoon, Commissioners. Thanks to the leadership of the Commission, electronic pre-authorization regulations, COMAR 10.25.17, have been in place for a little over 2 years, since February 2013. Staff has worked closely with stakeholders to support payers as they implement the electronic pre-authorization systems, which aim to increase administrative efficiencies by eliminating paper-based processes. Our November report to the Commission and legislators on payer progress highlighted the fact that all payers are in compliance with the benchmarks established in law, and they're deploying strategies to promote their online portals to healthcare professionals. We aim to continue to work with stakeholders in this regard. In an effort to align the current regulations with recent changes in the law, we're presenting to you today draft amendments for informal public comment.
Good afternoon, Commissioners. So as way of background, state law enacted in 2012 established the first 3 benchmarks which required payers to implement electronic pre-authorization processes in a series of 3 benchmarks in a phased approach. These included provide online access to a listing of the medical services and pharmaceuticals that require pre-authorization and the key criteria for making a determination. The second was to establish the online system, and the third was to render a determination with an established time frame. Amendments to the law in 2014 added a fourth benchmark that required certain payers to implement an electronic process to override a step therapy or fail first protocol for a pharmaceutical pre-authorization request. The draft amendments include language requiring payers to implement the fourth benchmark, as well as a corresponding reporting requirement to the Commission on their attainment of that benchmark. They should, the draft amendments also include requiring payers to provide notification to providers and their members on availability of the electronic override process. And since the current language already specifies the establishment of these online processes, we added language that payers must maintain their electronic pre-auth processes and report to the Commission upon request to demonstrate their continued compliance. In addition, the draft amendments would remove the expired payer reporting requirements in regards to their attainment of the first three benchmarks, and would also modify the time frame for the waiver process. Currently, the length of time for a waiver from obtaining any of the benchmarks is 1 year. We would extend that to 2 years and also make a change in the number of days they are required to submit a renewal request from 45 to 30 days. In terms of next steps, staff requests the Commission to approve the draft amendments that will be released for a 30-day informal public comment period.
Okay. Any questions or comments, staff? Ben?
So there's oftentimes there are questions about our waiver processes generally. How many payers or PBMs have sought waivers under the existing pre-auth regulations? Do you have that?
All of the payers at one point did. Currently, there's only about a dozen waivers for some of the smaller ones with very little market share. None of the larger payers have waivers currently in place.
Other questions or comments? Okay, thank you very much.
So just as a note, then this will be so-called, these are floating in the community. We would expect comment, a 30-day comment period roughly, and then these would come back for the next stage, which would be a adoption formal vote on the Commission to adopt these as proposed regulations, which then formalizes that process, and if there are no significant comments or concerns, then they would be finally adopted as final regulations, probably in June or July, depending on publication dates in the Maryland Register as to how that aligns, and assuming there's a broad consensus on these. One thing that on our electronic pre-authorization approach has been to build very strong consensus. And it's important, I think, to note that the work that the Commission staff did in really reaching a compromise on step therapy was an important achievement, given at one time providers and health plans and PBMs were very, very far apart.
Terrific. Thank you very much. Moving to agenda item number 5, which is recommended additions to MHCC's data release policy. We've had a number of discussions about information and data in the Commission over the past, couple of years, where it's become increasingly important to the Commission's agenda. Data is important to get it accurate. It's important to get it collated and synthesized correctly, and then for the Commission to really be participating with actively sharing it with third parties in an appropriate way so that they can continue the dissemination and information process. And Linda Bartnitska today is going to present staff's recommendations for the addition to the Commission's data release policy. Linda?
Yes. Thank you, Mr. Chairman, and good afternoon, Commissioners. Today I'm here with specifically requesting the Commissioners to make 3 additions to our existing data release policy, and those 3 additions were contained in the policy document that was given to every commissioner. I just want to point them out here and answer any of your questions about them and any other questions you might have. The first one is we're requesting permission to charge requesters seeking medical care database or District of Columbia Hospital Association discharge data file. There would be an application fee for each of the, whether it was the Hospital Association files from DC or for the medical care database. Then there would be a fee for the medical care database files that were actually made available to the requester. And our plan is to update our regulations to note that there will be charges for the above. But we think that once you approve, we can proceed with charging for the data in advance of getting the regulations adjusted. So we'd also like to initiate a privacy board. This would be a multi-stakeholder committee to review requests for the MTDB data. This would be in addition to the institutional review board option, which is available now. It was recommended to us by a couple of academic institutions who do lots of secondary data analysis and said privacy boards, which are easier to staff and can meet more routinely, are an excellent way to streamline reviewing requests by using the privacy boards when they're applicable. And until the regulations are revised to add the addition of the privacy board, the privacy board and IRB reviews would run in parallel because the IRB review would be required until the regulations are adjusted. So you would, that would be sort of like a trial run to see how everything works. And then thirdly, we would like to include a notice of the requests and approvals for the medical care database and the DC Hospital Association data on our website as part of a public transparency initiative. A little background information, the data release policy document that you all got summarizes the existing data release guidelines and practices that we've been using, and also these 3 recommended additions. The content was discussed in a series of multi-stakeholder meetings that we had last spring on data release policies. And the participants were very varied. They represented consumers, payers, providers, state partners, academic researchers, and others. And I think there were a series of at least 3 meetings that we held. And also I wanted to point out that MHCC has the authority to set reasonable fees covering the cost of accessing and retrieving the stored data for requesters. That's in statute. And charging for data is a common practice among states that compile databases of privately insured claims, as in Massachusetts and Colorado. And an applicant's fees will be based on the types and number of files and the complexity of the data request, meaning how much staff time is required to produce the files that the requester actually wants, because we want to limit the information to only what they need. Otherwise, it's overwhelming and a needless liability. So I've been asked to clarify what would be the impact on the existing commission authority. Right now, the commissioners are empowered to affirm or deny applications recommended for approval by IRBs. So if an IRB recommends it, doesn't mean the commissioners have to approve it. This same authority would be expanded to include applications recommended by a new privacy board. And IRB, just as to note, IRB or privacy board denials are only reviewed by the commissioners if the applicant can provide evidence of the board's failure to follow the process set out in statute. Not just because they don't like the outcome, but they have to give you evidence that there was a failure in the process. And commission monitoring of applicants' progress, security of data, destruction and or return of the data at the end of the analysis period, that applies to all entities who receive medical care database or DC hospital data, whether or not an IRB was involved. So that, if it happens through the Privacy Board, we would still do that. And those conditions are actually spelled out in the data use agreement that the requester has to sign before any information is given to them, any data files are given to them. The data files that would be subject to fees, just to be very clear, are the medical care database files, the private payer data, which could be quarterly now that we've started doing quarterly collections, or annual. The Medicaid MCO data, with our medical care database version, which come only annually because they're given to us by Medicaid and they're crosswalked to our variable names. And we can only give out the Medicaid MCO data if it's included with a private data request. Otherwise, they should go directly to Medicaid, and it's approved by Medicaid. And Medicaid is on board with this, and because we do want to streamline and make it easier for people to do comparisons across the two markets. And the data files that are available are typical data files that are used in processing healthcare claims, so enrollment or eligibility information, professional services claims, institutional claims, inpatient, outpatient, nursing home, et cetera, and then pharmacy claims. And the DC hospital data, there wouldn't be a charge for the files, only for the application fee, which is staff time to go through the request, make sure that the data will be safe, that they've, dotting our I's and crossing our T's. And I think we can move on to discussions and questions, but I was asked to let you know that it very quickly will be back, that there will be process. We have 2 applications right now in the pipeline. They're just waiting for your approval for the charging from RTI, Research Triangle Institute, to do a healthcare evaluation reform project that they have from CMS, and then also from George Mason University to do another healthcare reform evaluation. We've been contacted by several academic institutions and to be included in grants. If they get their grant funding for their studies, they'll be back to us. And one is local, which is Hilltop Institute at UMBC, and the other is up the coast, Harvard Medical School. We also have several, we received a couple of requests from Hopkins Medical School that they're interested in looking at best practices and some other initiatives. And then we even have, there are applicants for CON data. That would be the DC hospital discharge data, because that's the reason we hold that and give that out is for CON applicants or for other researchers. But I would say there's been a lot of interest, and we'll be back relatively quickly, I think, with the Research Triangle Institute and the George Mason application, assuming they get approved.
Let's start with a motion to approve the recommended additions to the data release policy. Second? Second? All right. Any questions or comments for Linda?
Linda, as you have so many pathways, and I like your diagram that was included in your presentation, how is the process handled when a request for use of data comes through an IRB, which is looking at lots of variables about use and value of going through that process? How does it work when it isn't an IRB base, it's not a research base with the Privacy Board? How do you reconcile the differences between that level of scrutiny and a request? I know the data use application, I probably haven't seen enough of them to know how much rigor is there in their explanation of what they're going to do with the data. And I don't know if the Privacy Board gets into. That's a hard question because you've got to be with boots on the ground. But I think I'm trying to reconcile the difference between one has a pathway with a great deal of rigor related to the research, and then the Privacy Board reviews as well. Mm-hmm. And they're probably I guess there could be some differences in how they are looking at that, but then there's this other line of requests that are not research.
Right, and the suggestion for the Privacy Board actually came from Hopkins School of Public Health, who uses, for secondary data release, uses privacy boards. And the privacy boards actually tend to be very focused actually on the research, trying to make sure that the person doesn't get variables they don't need to have for the research to be aligned. And so they're very sensitive to those kinds of things. And so they're very focused on those issues. And the difference, which is not to say that IRBs aren't, but where as long as no one's going to get the names of patients to call them up and ask them questions, then the Privacy Board doesn't have to contend with two things. One, the risk to the patient of finding, in the whole process of interviewing, all of those anxieties, all those tangential things that come with human subject research. But so the Privacy Board doesn't have to contend with that, and it has it's easier to staff. The requirements for who has to be on an IRB for it to be a valid IRB are pretty strict. So they're kind of hard to have would be very difficult for us to have our own IRB. We have a designated IRB right now, and we think that if we actually had the Privacy Board in-house, we might get better, more detailed reviews for the kinds of releases that we're giving, as opposed to using a designated IRB that may or may not be as sensitive to some of the variables, because they're not aware of what the variables are actually contain or what they might be doing, if you know what I mean.
Mm-hmm. Just another point of maybe to clarify, there's a great deal of rigor in the IRB process, and then there's the privacy. But it's those that fall outside a research question about, in the data use application, to make sure the same level of scrutiny exists for that are not research.
You're right. I would say,
and that's the trickier place, because you have to really, and I haven't seen enough data use applications to know how rigorous that explanation is in that document, because it's not research.
Right.
It has nothing to do with an IRB.
Actually, we consider it to be research. It's the same. So we do call it research. Our application mimics CMS's application for Medicare data. So it's very detailed. It's especially detailed around how you'll keep the data secure. You have to justify using the sensitive variables, why you need them, why you couldn't do it without them. So that same application would apply to both. And CMS is, we find it to have been very useful for us, and so we're going to emulate it here. And so that same information that would go to the IRB is the exact same information that would go to the Privacy Board. Is that really what you...
Yeah, I'm looking for the same rigor across both of those paths, as well as what I also understood is at the end of that period, and they're publishing the data or making some publication associated with it, that there's also the review, that they stuck within the boundaries and they're not extrapolating beyond what they asked for.
Well, right. I will say that probably, if someone wants to draw wild conclusions from the results they produce, we don't sit in judgment of their
when they go beyond the boundaries of their data application.
It's right. So if that's helpful.
Thanks.
Sure.
John?
Is there a definition of requester? And I guess I'm asking, is anyone exempt from the fee? For example, the people who provide the data in?
I think you make an extremely valid point. I think there is, so for, let's say, a carrier would want to get data from us. The question becomes, what do we do about the fees? Do we waive them? which I think is a possibility. I think that's a possibility. But in this case, right now we're at this point where we said that it would be individualized pricing based on the number of files and the complexity of the data request. But I think it's also possible that as we move forward, we may want to create some categories. We may want to create a state agency category, for which there are slightly different rules around payment, and we may create we may want to create a carrier or data submitter category that may or may not, but it will be up to you. That's what I would say. Is it will be up to you.
So just to be technically clear, the policy is giving you some license to sort of set the right fee schedule within your judgment, and that's not kind of coming back to the commission, if you will. It's just we're given the authority within the scope of the policy to create a practical fee schedule.
Yes.
Just wanted to clarify that. Okay. Diane.
So while I appreciate the question and thinking about whether there should be different categories of fee schedules based on the requesters, I would urge deep thinking about the value, particularly if it's an aggregated data set. So an individual data supplier is getting more than they gave. So, if it isn't a fee schedule that comes back to us for review, it would be, I would be interested in seeing at least what are the parameters that are established, even if it's not the set.
Well, in the spirit of transparency, I would want all the details of the fee schedule to be shared with the commission. It just won't come for a vote, if you will.
Got it.
We can have that informal fee schedule.
Some consideration. The other area, and this is just a point of clarification, is there actual payment information in the data that would be available?
Yes, there is actual payment. The question is, and I think we take this really seriously, if you get actual payment information and you get physician identifiers, then we would map the exact carrier with whom you had that relationship.
That helps. Thank you. And so the next question is, in looking through the information, I couldn't find where there are, or if there are, parameters in terms of what types of uses are approved, and if there are any types of uses of the data that just set out from the get-go to say this is not what the data should be used for, or is the approach to be silent on that?
Well, I think I was looking at the IRB board regulations, and in there I think there are three. I don't have them sitting here, but one of them is, that you're sort of required to consider whether or not it's in the public good. I think that's like item number one, is in the best interest of the public. So there are some guidelines for you all. I don't think it says that no one is verboten. It doesn't say, oh, no one can use it for A, B, or C, but it does sort of ask you to, it has some parameters. I think there are 3 or 4 that you're supposed to use when you make your judgment.
So the IRB isn't just looking at protection of the data and protection of research subjects, but also how the information would be used. I'm thinking about potential uses from a competitive standpoint, from a marketing standpoint, as it sounds like. Those would be probably at risk for not receiving approval if there isn't a clear value for the public good.
Well, I would say the IRB probably isn't in as good a position. They're supposed to make sure that it's a legitimate request, and that the data will be protected. The onus for being in the public good is on the commissioners, I think. So that's why only if it gets approved as being a reasonably sound, not wild, secure data, but if it came to you and you said, oh my gosh, no way, then...
Well, the point would be that the applicant would make the case for whether it was in the public interest, but the commissioners, as the final release of data that was deemed sensitive, would make the conclusion of whether that requirement had been met.
Maybe just to help, can you outline the current state? So that was really helpful to hear the pipeline, but just in the last 12 months, how many requests for this kind of information have we had?
We haven't in the last 12 months. I don't think we, in the last 12, have we given anything out?
Why don't you come up here, Srila?
Oh, right. I would say HSCRC. There's some people who, by rights, get the data. HSCRC is one of them who's gotten the data.
So HSCRC has received data and will be using it as part of the waiver monitoring process. The Maryland Insurance Administration uses it currently to evaluate for rate review. It's part of our grant requirements as well. The exchange has used the data in doing, for example, their reinsurance analysis, which Hilltop actually did. So Hilltop has received the data. We are currently in the process of releasing it to Medicaid ultimately, but housed at Hilltop for Medicaid-related analysis. So I think it has been actively used. There was a study in Prince George's County, which they let out a contract, so their contractor has received the data. So those are current existing releases of the data. I think because we were in this evaluation process of how to do the data release, some others, notably academic institutions and some private companies, have been sort of held at bay trying to do this. And for that, as I think Linda described, there are several academic institutions that have expressed interest, notably the two schools of public health, Hopkins and University of Maryland, are actively interested, and those discussions are ongoing now. And
so let me just make a point or two. I think that we're going to be in a really unique situation to really try to shape the market for this data and to create sort of the standards. And so it's not surprising that initially in the market you have people who are very facile with data and who are coming to it because they know it. But there are a lot of people who are out there who probably could use the data and use it for actions in the public good, but don't know of the data or how to use it. And so as we're thinking about costs of the institution, I think the cost to actually educate a number of the stakeholders on how to use it and almost give examples. So if there's a primary care practice group that says, hey, who are the specialists that I work with? Can I understand what their performance looks like? That seems a legitimate question. If third parties want to share it in a different sense to the consumers in a different way than we do, that could be another use. So you could really see this market sort of expanding if we spend some time sort of educating people in the right use, and as a commission decide which direction it wants to go. So I just would encourage us to not necessarily be passively responding to requests, but rather deciding the direction we're going to go.
I would say that one of the things that we haven't brought up because it's a little further down the pipeline, and we can't actually predict, but we have the benefit of having an additional staff person, and we think that that there's a market that we can kind of help along if we create some public use files that are free, that have summarized information that people can download and look at, and then become aware of the data, and then perhaps come to us, smaller companies, and actually request data to take those smaller entities that could benefit from the information and have someone extract it for them, because most people, the problem is extracting the information from the data. But we think so one of the things we will be doing is trying to create some public data sets as part of advertising, which would be an investment.
And I think to add to that, I think to help those who, even that might be complicated, we've discussed, we have BI tools and so forth, so we're thinking of creating a simple query tool so that at least the basic requests, how many of this or that are happening in Maryland, those basics could be, to make it more accessible. And similarly, I think we've engaged our database vendor, and Hilltop has expressed some interest. So for those who have interest in what the data might offer but don't have the skills, that they could contract with, not done for free, but they could contract with these experts in the data, that is our database vendor, Social and Scientific Systems, or Hilltop, which is developing expertise in this data. So that could be another avenue through which those who know already can help some of these other organizations.
Sure, just quickly on that point, I understand the need to charge for this, and it sounds like there's capacity to pay from the applicants that you've described. But the value of this data extends also to smaller groups who may not have that capacity, such as local health improvement coalitions or health enterprise zones or consumer groups. And so I would hate to see that our regs with regard to fee schedules would be a barrier or an impediment to small nonprofits that are not institutes, that are not commercial or academic enterprises accessing data. So it sounds like the regs that you are envisioning would give you some flexibility, some discretion in making a judgment as to what that fee would be.
Right, and I would
so in addition to perhaps the data suppliers, the carriers, as well as state agencies, I'd suggest that you think of a category that has to do with, I don't know, the grassroots category, or something that is it's nonprofit, it's looking at community health interests with absolutely without deep pockets. So that would be a suggestion.
I do think that those are some of the county health officers in particular were one of the groups who were thinking when we thought about those public use files that had summarized data at, let's say, a three-digit zip code level, or that would make some things easy for people. And that if we have our business intelligence query tools, where you could see, so that without having to hire, because again, even if they got the data, they would have to hire somebody to do the analysis, and that there's still cost. So we're trying to think of ways to make as much available for free.
Yep. Other questions or comments? Okay, then yes.
This is excellent. I think it's wonderful that we're moving in this direction, and that there are states out there. Oregon, and I know I've mentioned this, Oregon is a great model. For example, they've got a number of data sets that they make available. Certainly, to quote Frank Zappa, why reinvent the wheel when you can steal the whole damn car, right? So there's some great examples out there of other states that have gone down this path. And anyway, so totally applaud what you're doing. Thank you.
And the mother's reply was,
we'll make sure the minutes reflect Frank. Absolutely. All right, so we're going to now take a vote on the recommended additions to MHCC's data release policy. All in favor? Aye. Any opposed? Motion carries.
Thank you.
Aaron, it's your turn to present an update on legislative activities.
So I'm going to be as brief as possible, since this is basically a regurgitation of last month. I'm sorry. So March 9th was the 55th day. That's the last day that a bill can be introduced before the suspension of rules. And Monday is crossover. So anything that hasn't reached the opposite house by crossover is essentially dead. The first two bills we'll talk about, SB 92, HB 230, we talked about last month. It's the assignment of benefits legislation. They both passed their respective houses, and as of this morning, they were both scheduled in the crossed over and scheduled in the opposite house. The Senate bill was scheduled for a hearing in the House on the 26th, and the House bill was scheduled for a hearing in the Senate on the 31st. Excuse me, SB 320, HB 602. We had a lively discussion about this bill last month. This is MHCC uterine fibroid study. As you see in red, it said the sponsors are currently working with another state entity to provide staffing. As of this morning, when I checked, this bill was amended on the Senate floor to include the University of Maryland School of Medicine as the entity that would be convening the study. SB 539, HB 944, oncology, self-referrals. That was heard yesterday in the House, in the HGO committee. as was the MRI patient referral bill that was also heard yesterday in the HGO committee. Now they would have to reach the House floor and pass over to the Senate before Monday. This last bill was introduced a few weeks ago. It affects the CON statute as it relates to nursing home bed capacity. It involves a contested case before the Commission right now, so we can't really say much more. It's in the House Rules Committee, and we will keep following it as it moves through the process. And that's all I have. Any questions?
Thank you very much.
I think I beat my record there.
There you go. All right. On to agenda item number 7, the Hospital Palliative Care Pilot Project. Linda Cole and Rebecca Goldman are going to present an update on the project.
Thank you. Good afternoon, Mr. Chairman, Commissioners. I will provide an overview and some background on this legislative initiative, and Rebecca will present some of the initial results and topics to be covered in the final report. As a point of reference, palliative care is defined in the legislation as follows: specialized medical care for individuals with serious illnesses or conditions that is focused on providing patients with pain relief from the symptoms, pain, and stress of a serious illness or condition, whatever the diagnosis. It has the goal of improving quality of life for the patient's family, and other caregivers. It is provided at any age and at any stage in a serious illness or condition, and may be provided along with curative treatment. As you recall, we provided a status report to you last April on this legislation, the request for application process, and the selection of our participating pilot hospitals. Just to review briefly, House Bill 581 from the 2013 session asks the Commission to study palliative care programs and indicates the General Assembly's interest in developing standards for hospital palliative care. It requires that the Commission work with the Maryland Hospital Association and the Office of Healthcare Quality. The Commission was directed to select at least 5 pilot hospitals in a manner to ensure geographic balance. Pilot programs, according to the legislation, must collaborate with community providers, gather data on cost, savings, access, and patient choice, and report to the Commission on best practices to be used in the development of statewide standards. The Office of Healthcare Quality and DHMH is directed to develop regulations based on the results of this study, and the report is due to the General Assembly by December 1st of this year. Staff convened a steering committee that included both the Maryland Hospital Association as well as the Office of Healthcare Quality. We learned of the work of the Maryland Cancer Collaborative, which is also collecting some information on Maryland hospitals' ability to provide palliative care, and included them as well. We also have palliative care researchers from Johns Hopkins and from CMS. Staff conducted 15 phone interviews that covered 19 hospital palliative care programs. We then developed a request for application process. The criteria included a minimum of 50 beds, which was a legislative mandate, sufficient staff, sufficient volume, which we defined as a minimum of 200 cases annually, resources for data collection, collaboration with community providers. As part of the RFA process, 14 applications were submitted, 3 were assessed as not meeting minimum criteria, and 11 hospitals were finally selected. This slide shows the hospitals who were selected as final pilot participants. As you can see, they vary in size and geographic location. The second column indicates the number of licensed hospital beds as of fiscal year 2015. The projected annual caseload column indicates a range of projected caseload based on both our interviews with providers as well as the first quarter of data reported to HSCRC multiplied by 4 to provide an annual estimated caseload. I'd like to briefly describe some of the work we've undertaken on this project since our report last year. After the selection of the pilot hospitals, we established a hospital palliative care advisory group, which included the representatives of the participating hospitals as well as the other participants whom I mentioned. We established subcommittees to discuss in small groups with the providers certain components of the study, including definitions for how to define and measure palliative care, standards, how preferred practices should be assessed, out-of-hospital experience, including what data, if any, is available on patients after they leave the hospital, and satisfaction surveys. Is there a way to measure satisfaction among palliative care patients and their families? We are grateful to our pilot hospitals for their participation. Our goal was to use existing data sources to the extent possible in order to minimize the data collection burden on the hospitals. In our discussion with the pilot hospitals, we learned that they all participate with the Center to Advance Palliative Care, or CAPC, in their national data collection. The hospitals agreed to sign a release to permit us to access this data from CAPC, so we did not have to recreate it. This is primarily data that describes how the hospital programs function and provides aggregate information on total caseload. To date, we have CAPC data from the pilot hospitals for 2012 and 2013. We were also able to work with the pilot hospitals to agree to standard definitions for flagging palliative care patients and to report this data via the HSCRC hospital discharge database. We worked with HSCRC to develop regulations which became effective in June of 2014, and data collection began in July of 2014. We now have the first quarter of data from HSCRC, and Rebecca will present more detail on the flagging process and data collection. This slide summarizes the selected data from CAPC hospitals. All serve adults and none serve pediatric patients. All report strong hospice collaboration, which is an important component of palliative care. As far as Joint Commission, one hospital, Union Memorial, is currently Joint Commission certified. 3 are preparing to apply, 3 would like to apply, and 4 do not plan to apply. The most common mode of practice is inpatient consultation. In addition, 4 have outpatient clinics and 5 have inpatient hospice beds. The top sources of referral by type of physician are also listed. In terms of telemedicine initiatives, Union Memorial has a pilot program funded by the Verizon Foundation, which funds tablets which are given to palliative care patients upon discharge. This permits the patients at home to Skype with hospital physicians and staff post-discharge to discuss their symptoms, medications, and other needs. I will now turn it over to Rebecca to describe the flagging protocol used to collect data from HSCRC and the next steps.
This next slide falls under the realm of the definition subcommittee, and it will under the patient experience subcommittee as well. What we wanted to do, and I think you were given a proposal for this last time we met or last time we presented to you. These are the flags that we're using in the HSCRC inpatient data. We developed these flags with the help of a subcommittee made up of some of our advisory group members, particularly some of our pilot hospitals that have a more developed data collection process at their site. So we're categorizing patients in one of 8 under one of 8 codes. One is your sort of traditional palliative care patient that is seen. They're identified as an appropriate patient and they accepted palliative care recommendations. 2 is an important subgroup to distinguish because these are patients that were seen for a consultation and accepted the palliative plan of care which specified hospice care. So in identifying these patients, we can see the overlap and the relationship between hospice and palliative care that exists in some of our hospitals that you'll see in the next slide. And 3 are the patients who received a palliative care consult and did not accept that palliative plan of care, so they have been exposed to palliative care, which was one of the elements of legislation asked us to address, but declined that palliative care at the time of that consultation. 8 It's a catch-all category that we created when we heard that some of our pilot hospitals may not be able to code their patients 1, 2, and 3 effectively day to day. It turns out after planning, after getting those processes at each individual hospital established, all of the hospitals preferred and told us that they would use that 1, 2, and 3 code that we said was really better for us, and they agreed that they didn't want to be the only hospital that was just using the 8, I think. So it was agreed that the pilot hospitals agreed not to use that 8. As you'll see in the next slide, however, because we allowed them to use 8, some of them did use 8 the first quarter, but we are doing what we can to avoid that in the future. In the case of Suburban, I'll just go down the line of those that did use 8 and ensure that we've responded to those. So in the case of Suburban, we're actually recoding the patients that used 8 because there was some miscommunication between an administrative assistant. It's sort of a data entry issue. Same deal with Howard County. We're working to recode those. In the case of doctors and Johns Hopkins, we're going to try to avoid that in the future, but we're unsure about what to do with those 8 patients at this time. We'll deal with that in the data on the back end when we analyze this data. But there are enough patients coded other codes more specifically to be used during the data analysis that we can. We don't necessarily need those. So you'll see we coded about 1,500 patients for this first quarter as palliative care patients seen by those specialty palliative care programs in our hospitals. That annualized would be about 6,000 in that caseload that we'll be able to look at the site. So very quickly, we'll go over what we expect the report content to include. It will include, of course, a literature review on palliative care. This is a specialty that has grown, it seems like, substantially since the early 2000s, particularly in our Maryland hospitals, but also literature seems to date back until then. So it's a specialty with its own training models and modules based around and with an emphasis on its unique social, religious, and ethical issues. It's got its own advocacy organization, CAPC, that Linda described, and its own body of research relating to all of these things in the specialty. However, it's still largely non-regulated. We are sort of on the forefront of our research right now, according to CAPC and the other industry experts that we've talked to. We find in hospitals in Maryland that these specialty teams vary hospital to hospital, even among our own pilot programs. So we'll look into those differences. We'll include the profile of the Maryland Hospital palliative care programs that we have information on, which are about 25 right now. So it's because the Maryland Cancer Collaborative and the Maryland Hospital Association have already collected some information about what hospitals in general say that they have specialty palliative care programs. We'll report on that because that information is available. And that information includes things like whether or not they're interested in Joint Commission certification, the services that they provide, and some of their processes of care found at the hospital. After that background, we'll delve into and specify the scope of our own project, considering the legislative mandates in the Senate Bill 581 that Linda went over. Next, we are specifically required to report and recommend on best practices that we find in our pilot programs. We are going to get more information about that using the 38 preferred practices endorsed by the National Quality Forum on palliative care and hospice care. So what we're going to do with the survey that's coming out this week or next for our 11 pilot hospitals is just see how they stack up and align with how they stack up with those preferred practices and how those preferred practices align with the Joint Commission requirements. Next, we're going to detail the use of hospital services, and that's where we will be using the HSCRC inpatient data to develop our patient population profiles and use and charge data for these services in Maryland inpatient hospitals at our pilot sites. We've outlined the next steps that we foresee in the near future. We're going to submit the preferred practices survey to the pilot hospitals. We're going to have them fill that out in the very short term. again, that survey is being reviewed by a subcommittee that we've developed and will be put out next week. So what we're going to do then, after we get that survey back, is convene the pilot hospitals to review that data. We'll present what we found from that survey around, we're foreseeing May. We're reviewing the first 2 quarters of HSCRC data with our advisory group in June when that data is available. And we'll review the 2 years of CAPC data, or we'll present it. We are reviewing that data right now, but we'll be presenting that to them in June and anyone else who's interested in seeing that. By August, we'll develop the draft report. By September, we'll reconvene the steering committee to talk about the draft report, respond to that committee feedback by October, submit the report to you by November, and submit a final report to the legislature by December. The information about this project can be found on our website under the subgroup. There's a work groups tab on the left-hand side. Just go there if you want any updates, or ask Linda.
Or the link.
Just click on the link.
Click the link. Thank you very much. Any questions for Linda or Rebecca? John?
Does this fall under the hospital waiver, the global budget? Do you know?
It's not specific to that. It's the service that's provided within the hospital.
Right.
I think some of the hospitals see it as beneficial to them because in some cases palliative care is useful in terms of reducing readmissions, reducing length of stay, keeping people out of the hospital, which may help them meet their goals.
The payment's outside the waiver then?
The payment is part of hospital payment.
Part of the waiver, okay.
Other questions? Yeah.
One quick question. You made reference to the CAPC certification. Union Memorial is the only one that has CAPC certification.
Joint Commission.
Joint Commission, okay.
Right.
One of the things I did note about Union Memorial is it had a pretty low volume of discharges. Is there any thoughts on why they might be low relative to hospitals of the similar size? Sort of don't mean to ambush you, but
no. So we looked at the first quarter of data and compared it to overall medical surgical patients and the share that they have overall. And the shares of the palliative care patients that they reported in the first quarter fairly align with the shares of total MSGA patients that they have in Maryland for the first quarter. All these programs are different, and Union Memorial believes that it's to their benefit to be Joint Commission certified based on their missions and goals, et cetera.
And in terms of the volume, we did, at our last meeting with them, we presented the initial data and asked for their feedback. And some of the hospitals that are newer to this felt that some of their referrals were inappropriate, that they were getting patients who were really hospice patients. Union Memorial felt that they had been around long enough that they were getting more appropriate referrals. So the numbers may reflect that as well.
Question on costs. It's sort of listed as the scope, but are you guys planning to go into a little bit more detail around the economics of palliative care? So outside of Maryland, most institutions find this to be they're losing a fair amount of money on the service and need to make it up for in other ways, which then just sort of brings up the question of the relationships with other referrals and what have you. Are you going to shine light on that issue here?
Do you want to respond?
Well, I think, as Rebecca mentioned, we'll be doing a literature review, so we'll look at what's happening in other states. We will also be having the data that's in the hospital discharge abstracts. We'll be able to link the palliative care patients to the data available there.
But is it a hospital view only, and does it take into account physician revenue and physician costs?
So I think to take a step back, the overarching goal of the legislation and these initiatives like this that exist at the Maryland Cancer Collaborative and within CAPC are to increase the access to palliative care in general. We've heard a number of different things from our hospitals regarding how the administration looks at the costs and benefits of this service, and we will be profiling sort of and describing how each of the hospital's administration responds to our specialty care team's management of their program, and what goes into looking at whether or not they think and why they think the program is worth supporting.
My point is that I think just trying to get the facts and trying to actually just sort of put the facts together, and then maybe there might be some questions about whether there's too sensitive to share it by institution versus blinding. But I think that seems like that's within scope if you're trying to get a sense of what the costs are really of this, so. And knowing that it's been an issue in other states. So I'm not saying what the solution is, but just to get a much better sense of the economics and the cost.
Yeah, we should have that descriptive information on the palliative care patients and variations between hospitals within hospitals.
Okay.
So I think from the standpoint of what the capabilities are within this study, it's likely that we can look at hospital costs. I think it's going to be more challenging to capture professional costs and perhaps some costs associated with non-facility and non-hospital services, such as services provided by hospitals, for example. But we'll certainly try to have a broadest scope in terms of cost assessment as we can.
Okay. Thank you very much.
Thank you.
Next item is plans for enhancing the health plan performance guide. And Miriam Raham, Charmaine Robinson, and Eileen Witherspoon are going to provide an update on the improvements to the Maryland Healthcare Quality Reports website, including plans for converting the Commission's Health Plan Performance Report to an online consumer tool.
Good afternoon, Commissioners. Today we'll be providing a brief review of the Maryland Healthcare Quality Reports website, as well as some pending updates to the website. This is our mission statement for the new website. Just in a quick summary, the Maryland Healthcare Quality Report site is establishing an integrated resource that allows consumers to access all the healthcare data reported by MHCC through one website. The first release of the site was completed in November of 2014. The new design has allowed for further expansion into reporting on new provider settings and including new types of data, such as health plan data, which will be discussed later on in the presentation. The website is also more flexible and can evolve as our own reporting needs evolve. And a big plus has been that staff can go in and edit and add content as needed. The new site also reflects closer collaboration with other agencies as well as with consumers. We've streamlined our data collection process by bypassing the parallel data processing system that we had with CMS. Instead, we are using their downloadable hospital compare file for reporting on core and HCAHPS measures. We've also been using methodology developed by HSCRC to report on the top 25 medical conditions in hospitals and for the state overall. Additionally, we've expanded our data collection policies to support, not only our work, but as HSCRC's quality-based reimbursement program as well. We've also, in the development of the new site, been using the Agency for Healthcare Research and Quality's Monarch tool, Monarch being my own network powered by AHRQ. We've discussed this at some other meetings, but Monarch is a free tool that AHRQ has made available for generating state healthcare data reporting websites. We've been working with the Monarch team on their 6.0 release, which will be open source and would provide even greater flexibility in design and content. And we're hoping to incorporate the new release of Monarch into our July 2015 update. We've also been engaging consumer focus groups in reviewing the design, format, and content of the site. We recently actually completed a procurement process to hold additional focus groups. And these upcoming focus groups will have a primary focus on the inclusion of health plan data as well as physician data.
we have an update coming up next month. The April 2015 update, it will include a refresh of CLABSI data and C. diff data through calendar year 2014. Hospitals are currently previewing their data prior to us posting it live to the site. There will also be a refresh of the most common medical conditions and charges through calendar year 2014. And there will also be some new design features on the site. The homepage will have an updated photo slider that will allow users to fast forward through highlighted topics on our homepage. We'll also have a new text resizing option and a print function on the site. All those changes and the new data sets will be reviewed at next month's commission meeting. Next month, we'll also see the first phase of transitioning the health plan report from a PDF guide to a web-based guide. The first phase is going to focus on the CAP survey results, or member experience survey results. And I'll now turn over the presentation to Charmaine Robinson, who's the Chief of Health Benefit Plan Quality and Performance, and she'll discuss the health plan report in more detail.
Thanks, Miriam. Good afternoon, everyone. So to continue, for the health benefit plan report, the division currently does produce 2 reports for MHCC, and those reports are actually listed on the slide. We also do print 1 report for the Maryland Health Benefit Exchange. So the first report is the Comprehensive Quality Report, which provides performance data and information on all 5 quality measurement instruments. So these 5 instruments include the RELIC, which focuses on health disparities and disparities reduction in particular. The BHA, which focuses on provider network information, particularly in the behavioral health network. We also have the QP, which focuses on carriers' quality profiles and their continuous quality improvement initiatives in Maryland. HEDIS, which focuses on various aspects of clinical performance, and CAPS, which focuses on plan members' experience of care. So the second item, or the second report rather, actually if you could go back 1 slide. So the second report is the Consumer Edition Quality Report. This report highlights plan performance on CAPS, which is the only consumer-driven quality measurement instrument, and essentially expresses consumer satisfaction. The report that's not listed on this slide is the Exchanges report called the Maryland Health Connection Quality Report. This report utilizes authorized proxy data to calculate a rolled-up 5-star quality score that's based on aggregate performance on all 5 quality measurement instruments. So next we have the publicly reporting of quality and performance data on Maryland health benefit plans is currently supported by a number of contractors. So the services by these contractors includes the CAPS Survey Administration, the HEDIS audits and their clinical performance evaluation that's associated with it, as well as non-HEDIS clinical performance evaluation and report development. And lastly, RELIC data that's not only collected through the standard RELIC instrument, but is also collected through the RELIC member-level detail file. And regarding the last set of bullets on this slide, it's anticipated that there will be a continued need for all of the contracted services except for the report development of the static 3 reports that are currently produced more as a PDF style. And the reason for that is because we are transitioning to this web-based model, so a more dynamic type of report. So we could change the slide. And in creation of this web-based model, we're looking at calling it the Health Benefit Plan Guide. This transition has already begun and currently contains last year's CAPS data as a placeholder until this year's data is in. So it's intended that the new Health Benefit Plan Guide will continue to be developed in phases, and when completed, it'll contain all the information that's currently available in the Comprehensive Quality Report. The framework for the new Health Benefit Plan Guide indicates that the guide will contain a minimum of 3 layers. The first layer will be the landing page for the new Health Benefit Plan Guide, and will give users the option to explore information from any of the broad areas identified in the 5 column headings. The second layer will give users the option to choose from narrower subject areas that are in the bulleted selections in each of the corresponding 5 columns. And the third layer will give consumers the supporting data and information that corresponds to those selections. Again, the language might appear different when the website actually goes live, but for discussion purposes here today, I'll just use the suggested language as it appears on this slide. So under the first column for health plan finders, users will be able to locate plan offerings available in the region, in their region. They'll be able to get information about different types of plans like HMOs, POSs, PPOs, and EPOs. They'll also be able to get information on plan accreditation, provider networks, and quality improvement in Maryland. Under the next column, Health Plan Compare, that's where users will be able to compare plan performance on the CAHPS data. And again, that will be called the Consumer Ratings section. And again, the web page is under development for the whole thing. Again, right now, the 2014 data is in there, and we're anticipating that the 2015 data will take its place very soon. Once the clinical performance section and the disparities initiative section are both developed, users will also be able to compare plans based on their HEDIS measures and their RELIC measures. All relevant trademark and copyright information will be included throughout these web pages as appropriate, because some of these tools are proprietary. So on the next column, we have plans inside Maryland Health Connection, state employees and retirees, benefits, Medicare, and Medicaid. And users here will just be provided a brief explanation and convenient links right to the source so that they can get the information that they are looking for. And under consumer information, users will be provided information on statewide healthcare initiatives in Maryland, like the PCMH program, HIT, as well as Health Enterprise Zone programs, plus information on the top 5 chronic diseases impacting Maryland residents, as well as information on the childhood immunizations, which focus group members previously shared with us they really liked. And then last, under resources, users will be provided a fairly comprehensive list of a number of state, local, and federal resources for just about everything from the medically related things to the insurance related things. So there are also sites related to immunization protocols for children as well. Okay, and with that, I think we're ready to open it up for questions.
Thank you. Any questions or comments? Brad?
Thank you, Charmaine, and all the team for great work here. Just kind of an off-the-wall question. Does the Commission or perhaps MIA or anyone develop consumer information on dental plans?
So there are currently a few carriers that are also offering a dental benefit as part of the medical benefit. And right now,
or there's standalone dental carriers.
Or there are standalone carriers as well. So the standalone dental carriers currently are not reporting quality to the state. The Maryland Health Benefit Exchange does have the ability to require the standalone dental plans to also report on quality. And I think for this year, they have only required the QHPs, the Qualified Health Plans, to comply with reporting and to do so in line with MHCC's reporting requirements. So we're sort of helping to facilitate quality reporting for the exchange.
But for the Commission at this point, it's not on the horizon.
Well, we do have one quality measure that is contained in NCQA's HEDIS tool, and that's just for the annual dental visit measure. So in that regard, we're able to at least see how many members are at least getting an annual dental visit. And
it's just part of a growing understanding that oral health is part of human health, and more integration between dentistry and medicine and nursing. And so while the plans might be separated, that's probably an artifact that will change over time.
Absolutely. And actually, that's in part how MHCC has been able to broaden the scope of what measures plans are required to report to us on. So initially, they were not required to report on some of these measures, but now they are a requirement for reporting, and we have the capability to also add measures that may not be part of the national quality measurement instruments, like the one produced by NCQA, the HEDIS measure, or the one recommended by AHRQ with the CAP. We have 3 Maryland-based tools: RELIC, the Behavioral Health Assessment, and the Quality Profile. So what we are doing is conducting a QA/QI work group that not only includes representation from each of the main carriers in the state, but also includes consumer representation from whether they're individuals or consumer advocacy groups. The first meeting, inaugural meeting for that work group is anticipated for July, and we do hope to discuss various things related to quality measures for reporting and its expansion to address things for the exchange that we might be continue to do for them in proxy, and also address not just the medical benefit, but the dental benefit, and possibly at a very low degree the vision benefit, since the exchange also does have QVPs or qualified vision plans as well. So again, this will be done collaboratively with all of the carriers and input from consumers as well. And we hope to continue our track record of making progress with expanding reporting. And on that note, I also have a quick side note in terms of the RELIC. This year, I've been going out on the on-site audit, and we've had 2 carriers actually come back and share that they are looking at expanding the data that they get from their members in terms of the directly reported data related to race, ethnicity, and language.
Great. Was
primarily.
CareFirst one of them?
I'm sorry?
Was CareFirst one of them that was
Actually, yes.
Yeah, good.
Market
Okay,
share
good.
provider.
Good.
So, yeah. So yeah, we're very encouraged that we're having early uptake. It seems like it's been a while, but this is still relatively quick uptake by the carriers. And it's not being implemented yet, but steps are being taken, like baby steps, and we're encouraged. So.
Thanks, Ben.
Just a quick point on the dental collection of information on dental plans through the exchange. The data, the APCD, the MCDB data collection is taking steps to get information from standalone dental plans, but the traction is very slow. Keep in mind that under essential health benefits, pediatric dental has to be included through only pediatric dental, but it's going to be challenging. My understanding on the freestanding dental plans that enrollment's pretty small. Several of the plans of the dental carriers that offered plans in 2014 have expressed frustration that their uptake is quite small and are seeking exemptions from submission. We're working with the exchange to figure out, given the low volume of enrollment, what we ought to do. But I think there's the exchange too is interested, although uptake is small, in having a comprehensive picture of what's happening with dental utilization. But it is true that the capability of these carriers relative to health plans is quite limited. So it's going to take a while to fill out that objective as well.
Thanks, Ben. Glenn?
I am so excited about this part of our work. I think the work that you all have done on this over the last number of months has been wonderful. I I'm curious about the consumer focus groups that you've done and whether or not any reports exist from that, because you always hope that when you report quality data that people are actually going to actually look at it. And I'd be fascinated to know what people had to say about it, about how they search for information, and then also, are people using the information that we're presenting? So a little bit more understanding of how many people are actually going to our website and looking at this information too.
Well, we have held 4 focus group sessions, and they really were targeted for building the website. And we have a report that's not, we haven't released it or anything. It was a report that really is an internal document that summarized what we did and all of that. We can share that with you.
Yes, please.
Yeah. But we do plan on holding additional focus groups over the next couple of months. And that one, I think, will take an approach where we'll have a final report that we can actually publicly make available and post to the website. Okay.
And unlike on the hospital side, that it is used more by the lay consumer, on the health plan side, it's used more by employers and benefits specialists. So we have also targeted them in providing advice, advising us on employer-focused focus groups.
Diane?
So this is, it's a very strong segue to my question, which is in thinking about the center column, I love the connection to state employees, to Medicare, Medicaid, those who would purchase through the Maryland Health Connection. And I think about going the other way. So over to the health plan finder, if you've got a state employee who's coming to say, I want to look at health plans that are pertinent to state employees, meaning within the array of health plans that are offered through open enrollment, or I want to see the health plans that accept Medicaid, or I want to, is that in the plan for one of the ways that information about different types of plans could be categorized and viewed, or is that something that we could potentially include in the future?
I think it's definitely something that would be included in the future. With the static report, one of the limitations was that you couldn't really present a lot of this very specific information and keep it concise. It's already about 200 pages long. So we didn't want to overburden by adding more static pages. But once we go to the dynamic web format, what we're hoping to do is, first of all, not all carriers in Maryland operate in every zip code. So we're starting with providing the service areas that the different carriers might offer products in Maryland. And then it would potentially be able to expand to including some of the other plans that MHCC doesn't report on directly, like plans through Medicare, Medicaid, et cetera. And
to be clear, what I'm talking about is, given the information that we undoubtedly we have about the carriers, not just in the zip code, but to be able to say, I'm a state employee, or to say, in this zip code, what are the plans that are offered to state employees? And then I can compare, so it really directly provides value back to the state to say this makes it immediately usable for someone who's making a choice. And ideally, you want someone to make informed decisions based on the quality comparisons. But if we could help by building in, particularly for these clear market segments that you've identified in the center column, those might just be some natural starting places, and particularly starting with these categories to make it easy for people to go right to the plans that are relevant to who they're looking for.
We're at the early design stages. We'll look at how, whether we can implement that. I mean, I think it's in terms of the system as visualized as opposed to the system that will end up being operational as visualized. I think it's definitely very conceivable that it could be done. I mean, I think the other point that is always a struggle is that when you get to the point of an employee, a state employee, or exchange, a person is buying through the exchange or Medicare, that the CAHPS measures, consumer measures, are not going to be specific to that geographic area, but nonetheless, it's going to be useful. I don't know if you
how we design the other web pages and how we pull information together for display. So this is really helpful.
Any other questions or comments? No, thank you very much.
Thank you.
Terrific job. Last item, Ben, you're going to provide an overview of upcoming initiatives.
So thank you very much, Chairman Tainio. First off, I want to just note that that we have been, our health planning staff has been working very energetically with a host of applicants. And although you won't see those next month, there are a number of projects that are very close to either docketing or have been docketed or will be docketed. So please pay attention on our website to the status of our projects going forward. At the next month's meeting, of course, we'll know the legislative session will be over, so there'll be a comprehensive wrap-up from Aaron on where we stand. As just mentioned, there will be an update on our hospital guide. I'm very excited that we'll have more complete, more accurate information on price variations among Maryland hospitals for 2014. That'll be interesting because that's really the first year in which global budgets in any way took effect, and how prices vary under the global budget methodology is sort of interesting because hospitals have some flexibility to adjust their charge masters to make certain they hit their global budget targets over a year. So you can see some price variation across the year. How that's going to come out in terms of average prices per procedure is something I think we'll all be educated on. We will have one CON application, I would think, and then two important presentations I think will be also held at that meeting. The first will be something we do annually, which is the presentation on spending by the privately insured. That will be for 2013 and will be a precursor to our more ambitious efforts to really begin to track more precisely spending by the total spending by the privately insured, useful for our purposes, but also helpful for our colleagues across the way, as they are required, to monitor what's happening as a result of the new global hospital payment model on total spending. And lastly, we will be presenting our findings on our patient-centered medical home project. Anyone that does evaluations knows, I think, that there are always glitches, data limitations, et cetera. And our team here in-house, including David, Melanie, Linda, Srinivas, have done a really a great job in working with our contractors from Johns Hopkins and from Impact International to get this work done. We're a bit behind, but it's due to data limitations. Like many of these, the really independent evaluations of PCMH programs across the country, I just want to say that the findings are positive in some areas and not as favorable in others, and I think that's consistent with some of the work that's been done by Meredith Rosenthal and others nationally that shows progress and hope. And if you're definitely a proponent of advanced primary care, there's a lot of hope to have. If you're more dour, I suppose you would say we want to move on to the next objective. But I think our findings are going to be consistent with what we are seeing nationally and results from Pennsylvania and other jurisdictions. So it's going to be, I think, presented in segments, but it will be a comprehensive picture and consistent with the directions from the legislature.
Thanks, Ben. If there's no other business, I'll entertain a motion to adjourn. Second? All in favor? Meeting adjourned.